And in the interest of time, I see that people are continuing to join. I'm going to go ahead and just jump right into it. We have a full webinar today. So again, good evening, everyone, and thank you for joining us today. Welcome to CBHN's Health for Life series on prediabetes and prevention. My name is Amber Busby. I'm the Associate Program Manager at the California Black Health Network. Today, we are here for session 2 of the 7-part series, Control the Controllable. In this series, and specifically today, we have the pleasure of hearing from Dr. Candice A. Price, who I will introduce momentarily. And today we will talk about Life's Essential 8 and the importance of maintaining cardiovascular health as it relates to prediabetes management. While the webinar is designed to be interactive throughout the session, you will be muted. We encourage you to use the raise hand feature for comments and questions, and or to put any questions in the Q&A box, which you can find at the bottom of your Zoom screen. Before I introduce the speaker, I want to share a little bit about CBHN in case any attendees are unfamiliar with our organization. The California Black Health Network's vision is a California where every African American and Black immigrant has the opportunity to live long, healthy lives free from violence, racism, and health inequities, regardless of their education, socioeconomic class, zip code, sexual orientation, gender identity, housing, or immigration status, and have access to high quality and equitable primary and behavioral health care to avoid unnecessarily succumbing to disease. We do this through outreach, education, policy, and advocacy work. At this time, I am pleased to introduce Dr. Candice Price, who is a metabolism and nutrition scientist whose career has focused on understanding the development and prevention of obesity, type 2 diabetes, and cardiovascular disease. She received her PhD in endocrinology at UC Berkeley, where she studied alternate day fasting and the role of fat cells in the development of insulin resistance. During her time as an assistant professor at the University of California, Davis, Dr. Price investigated the mechanisms by which sugar-sweetened beverage consumption increases the risk for cardiometabolic disease in Black women. Her research portfolio also included examining the impact of naturally sweetened juice intake on health outcomes, the role of the gut microbiome and insulin resistance, psychological stress and sugar consumption, and the potential epigenetic effects of high sugar intake. In addition to her scientific career, Dr. Price is a certified diabetes prevention program coach and started one of the few DPP programs in the Sacramento region. Additionally, today we are joined by Janae Anderson and Dr. Michael Shadia. Janae is a clinical dietitian at the San Gabriel Valley Medical Center, where she provides medical nutrition therapy and education to patients in an acute care setting. Dr. Shadia is a physician at the LA County Harbor UCLA Medical Center, where he spent 3 years practicing internal medicine and running his own diabetes clinic. At this time, I am pleased to turn it over to Dr. Candice Price. Thank you for being with us again today.
Great, wonderful. Well, thank you again for having me. So today we're talking about maintaining cardiovascular health, and this is all going to be focused on Life's Essential 8, which in a moment you will learn exactly what that is. So before we get started on today's lesson, if you will, let's go ahead and see what everyone knows. Amber, can you go ahead and launch the survey? So which of the following lists 4 of the 8 components of Life's Essential 8? A, diet, sleep, smoking, and transportation. B, meditation, sleep, calorie restriction, carbohydrates. C, lipids, glucose, blood pressure, body weight. or D, body weight, glucose, sleep, and food logging? Okay, so most of you selected C, lipids, glucose, blood pressure, and body weight. All right, let's see if you all are correct. Go ahead and launch the next question. Okay, what is the recommended minimum level of physical activity? 120 minutes a week of moderate activity to vigorous activity, 150 minutes per week of moderate to vigorous activity, 300 minutes a week of low activity, or D, there is no specific recommendation for physical activity. And if you attended last week's webinar, you might know the answer to this. Okay, most of you selected 150 minutes a week of moderate to vigorous activity. Okay, next question. Okay, meeting Life's Essential 8 recommendations reduces your risk of which of the following diseases? And you can select as many as you like: cardiovascular disease, type 2 diabetes, cancer, stroke, or dementia. Oh, it's a single choice. Okay, well, go ahead and select whichever one you think. Okay, so you all said cardiovascular disease and type 2 diabetes mostly, and a few of you think stroke. All right, next question. I am over 60 years old and I am not meeting Life's Essential 8 components. It's too late for me to do anything about that to improve my health. Is this true or false? All right, 100% of you say false. We're off to a good start already.
Candice, this is the last one.
All right. I am only 25 years old, and even though I am not meeting Life's Essential 8 components, I'm young enough that I don't need to worry about meeting all of these recommendations. Is this true or false? Okay, some of you think this is true. Most of you think this is false. All right, well, let's find out. Okay, so everyone did a great job on that survey. We're not going to retake it, but take note today and see what you might learn. Okay, so just a really quick bit of background about Life's Essential 8. It used to be called Life Simple 7. So in 2012, the American Heart Association created Life Simple 7 as a simple diagnostic construct by which to measure, monitor, and modify cardiovascular health. Now, it was called Life Simple 7 because it was a compilation of 7 risk factors that, when optimal, were associated with cardiovascular disease-free survival, total longevity, and higher quality of life. Now, each criteria was identified as poor, intermediate, or ideal based on accepted clinical thresholds, meaning depending on what your answers were on the questionnaire, they would assess whether or not you're meeting that in the ideal range, intermediate, or poor. So that has since been updated recently. Last year, it's been updated to what's called Life's Essential 8. It is now composed of, as you can guess, 8 components, and these are all metrics of cardiovascular health. We will go through each of these today, some of these very briefly, and because there's so many components, we're going to move a little quickly, but some of these we will be talking in future webinars in more detail, so stay tuned for those. But the components include diet, physical activity, blood glucose, body mass index, blood lipids, blood pressure, nicotine exposure, and the new addition, sleep health. Now, there's an assessment that you can take, and we'll talk about that towards the end, and it's based now on a scoring system. So before I mentioned that you would be assessed based on either reaching the metric in the poor range, which usually meant you didn't meet it at all. Intermediate meant there was still room for improvement, or ideal, you were at the recommended level. Now that scoring system has changed to be on a sliding scale from 0 to 100, with 0 meaning that you're not meeting that metric, moderate, meaning you're meeting some of it, but not all of it, and 100 meaning you are at the ideal recommendation. And so this allows for a better composite of someone's cardiovascular health score, because we can better gauge, one, changes over time, whether or not you're improving or maybe even worsening in some of these categories. And that's really important when we're, one, helping patients assess their cardiovascular health, but also when you're assessing your own health through the Life's Essential 8 assessment questionnaire. And so why is following Life's Essential 8 so important? Well, we know that obviously, as you might guess, it reduces your risk for cardiovascular disease, but also type 2 diabetes, which is, what this whole series is about preventing type 2 diabetes. And when we prevent type 2 diabetes, we also prevent cardiovascular disease. It also reduces your risk for cancer. Cancer and its associations with metabolic function is actually not discussed much at all, but metabolic dysfunction is a major risk factor, especially obesity for cancer. Also reduces your risk for stroke and dementia. Now, if you attended the last webinar, which if you didn't get a chance to, I highly recommend that you watch the recording. That gave a lot of background on prediabetes and insulin resistance. So I won't go over this chart in full, but I'll just highlight the prediabetes diagnosis is based on an A1C of 5.7 to 6.4, fasting blood glucose of 100 to 125, or glucose tolerance test result of 140 to 199. Now, when you're taking the Life's Essential 8 assessment, you will be scored based on whether or not you have no history of diabetes and you are not pre-diabetic, based on these criteria that I just showed you, or you have no diabetes, but you have pre-diabetes. And then if you have diabetes, there's a metric based on essentially how well that diabetes is controlled. And so why is elevated blood sugar important risk factor for cardiovascular disease? Well, some of the consequences include elevated blood pressure, damage on blood vessels. This can lead to damage to the heart, and also elevated blood glucose can damage cells, something that's called oxidative stress, where we have free radicals in our cells and we don't have enough of artillery of other proteins that will fight it off. You are more than 3 times likely to die from cardiovascular disease if you have type 2 diabetes. And when compared to white Americans, more than 60% of Black Americans are likely to be diagnosed with type 2 diabetes. And so that's a really major risk factor for cardiovascular disease, like I stated before, if you have diabetes. You may recall from webinar 1, if you did attend that insulin resistance, when your body does not respond normally to insulin, in the liver increases lipid production, and this can lead to an increase in circulating lipids. So this brings me to my next component. Lipids. For Life's Essential 8 is specifically non-HDL cholesterol. So you may have heard that there are 2 main cholesterols that we commonly assess when we're looking at cardiovascular health. And these include low density lipoproteins and high density lipoproteins, LDL for short and HDL. Low density lipoproteins are thought to be the bad cholesterol, and high density lipoprotein, HDL, is thought to be the good cholesterol. So the LDL is bad, and I'm making this as simple as we can. So this hopefully will be as digestible as possible. But LDL is the bad cholesterol because it moves fat into the cells, right? This is what contributes to clogged arteries, for example. HDL is the good cholesterol because it removes fat from the cells. And so when we look at life's essential 8 components, they're assessing your risk based on your lipid levels, really by looking only at the non-HDL. So essentially, how much cholesterol in your body is the bad cholesterol, is not composed of the HDL. So this is basically meaning you take the total amount of cholesterol and you subtract the total amount of HDL cholesterol, and that will give you your non-HDL levels. If you have non-HDL cholesterol at a level of 130 or lower than 130, then you are at the ideal range, ideal threshold of cholesterol for preserving your cardiovascular health. And then as you go down the chart, you can see that you lose points depending on what range your non-HDL cholesterol levels are. And so the only way to find out what your cholesterol levels are to get a metabolic panel test done through your physician. Now, what's interesting and perhaps confusing about cholesterol levels is that Black Americans tend to have a healthier lipid profile, actually, compared to white Americans. So even in the insulin-resistant state, many of us can have seemingly normal cholesterol levels. So there's something called dyslipidemia. This is when you have an imbalance in LDL and HDL and triglycerides. You have basically too much of those lipoproteins and of the triglycerides. But Black Americans, we tend to have normal levels, even if we are insulin resistant, like I said before. And so this is a bit of a paradox because we know that we have higher risk of cardiovascular disease and higher rates of cardiovascular disease mortality. And so what this suggests really is that potentially the current clinical thresholds that we go by for cholesterol levels might actually not be as accurate for Black Americans or really anyone of African descent. We still need some research to be done in that space to really better understand that. But for example, 36.1% of Black women have elevated cholesterol as compared to 43.4% of non-Hispanic white women. And 20.7% of Black men have elevated cholesterol as compared to 28.4% of non-Hispanic white men. And yet Blacks tend to have higher HDL levels. So you want more HDL levels. That indicates that you're in the healthy cholesterol, at least that component of cholesterol is healthy, right? Because that's the good cholesterol. And this may be a normal range, even for individuals with type 2 diabetes. But what we're starting to learn, but not fully understand yet, is that this higher level of HDL may actually not equal better protection. And this is due to the function of the HDL. So just because you have more HDL doesn't necessarily mean that it's functioning properly. It doesn't mean that that HDL is working to clear that blood or to clear that cholesterol from the blood. So nonetheless, we go by the current thresholds, which are in the table I just showed you before. But I would just want to say that based on what we do know about this paradox of healthy lipids and higher risk for cardiovascular disease, it doesn't necessarily, just because you have healthy range of lipids doesn't necessarily mean that your risk, that you don't have any risk, right? It just means that your risk is lower. And one other important issue in our community is that Black Americans are less likely to receive statin therapy per the guidelines for the treatment of high cholesterol. And what we think, research has shown that it might be due to some social issues around medical care, bias, racism in medicine, the history of racism in medicine in Black Americans, and our trust of treatments, essentially. And so understanding how physicians can communicate better with patients of African descent, to help them to, better understand the use of the therapy, the need for the therapy, and its ability to reduce cardiovascular disease incidence. Okay, so this moves me on to blood pressure. So elevated lipids is also associated with higher blood pressure. I mentioned earlier that so is elevated glucose levels. We're not going to talk about this too much, but essentially, this is a chart for the lysessential 8 blood pressure measures and the points associated with these optimal or suboptimal blood pressure, systolic and diastolic blood pressure. So ideally, you want to be at a systolic level of 120 milliliters of mercury, and have a diastolic blood pressure of less than 80 milliliters of mercury. If you're between 120 and 129 over 80, then or over less than 80, then that's still elevated. And so you get a reduction of points there and so forth down the line. So, blood pressure is a major risk factor for cardiovascular disease. I'm sure you can all are all aware of that. And it's a very common in the Black community. In 2019, 30% of African Americans were more likely to die from heart disease than non-Hispanic whites. And 30% of us were more likely to have high blood pressure, yet more likely to also not have their blood pressure under control. African American women specifically are nearly 50 times more likely to have high blood pressure as compared to non-Hispanic white women. And actually, Black women have the highest rates of hypertension or highest prevalence of hypertension in the world. And so it's really important that we address blood pressure. And one of the barriers to addressing this really is understanding treatment, effective treatment amongst people of African descent. Interestingly, there was a study that was recently done that demonstrated that prescribing Black Americans based on an algorithm that came out, I think back in 2014, that was a race-based algorithm for prescribing blood pressure medication. And I think this was based on the finding that some Blacks weren't responding well to the hypertensive medications. And so as a result, their blood pressure wasn't being controlled very well. And so the medical community developed this new algorithm to try to better treat patients. And turns out it's not actually providing any differences in change. And it can actually be a little bit more detrimental even to, to treating Black patients, right? And so we have to come up with a better way for treatment. And one of those ways is providing more personalized treatment that's based on the entire person, other components of their social and psychosocial environment, which we'll talk about later as well. And this also includes things like diet. So now one way to control blood pressure along with diet, and we'll talk about diet later, is exercise. So the physical guidelines for Americans recommends 30 minutes of moderate to vigorous activity per day, 5 days a week. More specifically, 150 to 300 minutes a week of moderate aerobic physical activity, or 75 to 150 minutes a week of vigorous aerobic physical activity, or a combination of moderate and vigorous aerobic physical activity. So basically, the harder you work, the fewer minutes you really have to put in. In addition to that, they've added muscle strengthening activities as well. So 2 or more days a week of, let's say, lifting weights, okay? Many Americans don't meet these guidelines on only less than half are meeting the guidelines, and only 24.2% are meeting the guidelines for both aerobic and strength training exercise. Statistics amongst Black Americans are very similar. 40.7% of Black women are meeting physical activity guidelines, and only 47.7% of Black men are meeting physical activity guidelines. So when you take the Life's Essential 8 assessment, it's basically going to just ask you, I don't think it asks vigorous and moderate or light, but this, it does say specifically how many minutes of moderate to vigorous activity are you involved in every week. So if you're meeting the guidelines at least 150 minutes or more per week, then you've met the ideal recommendation. And of course, if you're not quite there and you're somewhere down here, then you know that there's room for improvement. I think oftentimes we don't really understand what is meant by moderate or vigorous activity. So really quickly, I'm just going to show you. This is a chart that lays out some examples of moderate and vigorous activity as well as light. One very easy form of exercise is walking. You can go walking during your lunch break, walking as long as it's not 100 degrees outside. So maybe walk in the morning instead, or in the evening if it's a little cooler then. But walking slowly is very different from walking very briskly. Walking briskly is considered moderate exercise. Walking slowly is just considered light exercise. So if you want to get in those that recommended 30 minutes of moderate to vigorous exercise, make sure you're really picking up the pace there. We're talking, you should be able to walk 1 mile within 20 minutes. Some examples of vigorous exercise would include bicycling at least 14 to 16 miles per hour, carrying heavy loads. So let's say you're moving and you're carrying a lot of heavy boxes for 30 minutes, hiking, etc. Now, obviously, some of these recommendations in terms of what's moderate and vigorous for you might be different from somebody else. So somebody that's 22 years old, running 2 miles at a pretty decent pace might be a little bit more challenging for someone who's, let's say, 75 years old and trying to get in cardio workouts. So sometimes it's about your own personal pace, and also depending on if you have any pre-existing conditions or injuries, you also it's always a good idea to consult with your physician before you start any vigorous activity. And if you have never done physical activity at all, starting small, obviously having some kind of support system to keep you motivated as well is always great. You may notice at the top here, there's something called METs. That basically means metabolic equivalents. So for moderate, 3 to 6 METs means compared to the calories that you would be burning if you were sitting down, these activities are burning 3 to 6 times the amount of calories, and that's why it's considered moderate. Vigorous activities are burning more than 6 times the amount of calories that would be burned if you were sitting down. So tune into webinar 4. We're going to be talking more about physical activity, including common barriers to getting enough physical activity and strategies for setting and meeting these goals. Okay, so smoking is one of the other criteria. Smoking is the #1 preventable cause of death in the United States. According to the Centers for Disease Control, American Indians, Native Alaskans, and Black Americans have the highest rates of smoking amongst racial and ethnic populations in the US. If you attended webinar 1, you may remember that these two groups also have the highest rates of type 2 diabetes, with American Indians, Native Alaskans in first place and Black Americans in second place. Almost 20% of Black Americans report using tobacco. And compared to other race and ethnic groups, Black Americans are more likely to have higher risk of tobacco-related deaths. In addition, just to tie it into the previous component, physical activity, if you want to maintain your maximum fitness and endurance, abstaining from smoking and protecting yourself against secondhand smoke is key. And you might notice and think that many of these components tie in together. And so I mentioned smoking is the #1 preventable cause of death in the United States. It increases the risk for type 2 diabetes by 30 to 40%. So this is why stopping smoking is so critical for diabetes prevention. It's linked to 1/3 of heart disease deaths and 90% of lung cancers. This also increases risk for coronary heart disease and stroke. It worsens lipid levels as well. It increases inflammation and, of course, is associated with worse glycemic control. These are the recommendations for Life Essential 8. Obviously, never have smoked. That is the ideal metric that we want to be at for smoking. Smoking for Life Essential 8 is actually technically now called tobacco exposure because it now includes both secondhand smoke as well as vaping, now that there's other forms of smoke inhalation. And then, of course, if you're a current smoker, unfortunately, you don't get any 0 points. And so this would be one of the areas that you would work on as one of your goals in achieving optimal cardiovascular health. Okay, now we come to sleep. So greater deep sleep is associated with lower risk of type 2 diabetes. We'll talk more about sleep in webinar 5. So I'm not going to go into too much detail, but we often usually hear about REM sleep, rapid eye movement. And now we're learning that deep sleep, which is different, actually may even have a greater impact on health. Too much or too little sleep is associated with coronary artery disease. And unfortunately, Black Americans are experiencing more sleep debt than white Americans. So this means sleep debt would be you're getting less than 6 hours or 6 hours or less of sleep on a regular basis, and includes middle of the night wakings and less deep sleep. So not just the duration of sleep is important, but also the quality of sleep is important. In webinar 5, we're going to talk about how this is related to your diurnal clock and your hormones that regulate your metabolism. Okay, so for Life Essential 8, the sleep recommendations, ideally you would be between 7 and 9 hours, and that would be the ideal threshold. 9 to 10 hours, remember I said too much can be bad, so you actually lose some points there. And then of course, too little, you even fewer hours than 7, you get fewer points. Okay, very briefly, we're going to talk about diet, and then I'm going to move on to weight because we have a lot to talk about with weight. So diet, as you can imagine, is of course an important component of Life Essential 8. For Life Essential 8, it's actually based around what's called the Mediterranean eating pattern for Americans. When we're looking at this at a population level, it's based on the DASH diet, dietary approaches to stop hypertension. And so there in the questionnaire, it basically asks you if you're consuming, how much you're consuming of particular food groups. This might be, say, legumes or beans and whatnot, or fish and vegetables. And so this Mediterranean eating pattern was created as a simple way to assess an individual's consumption of what we call a Mediterranean-like diet, which is essentially what the DASH diet is modeled around. So to give you some examples of food types that this would include, obviously vegetables, we can never get enough of vegetables, and making your plate as colorful as possible. Fruits, whole grains, fat-free or low-fat dairy, fish, poultry, beans, nuts, and seeds, and vegetable oils. Now, the recommendation limits fatty meats, right? So things like beef and pork and cured meats, full fat dairy, sugar sweetened beverages, sweets, and sodium intake. We'll talk a lot more about nutrition in our next webinar, so please stay tuned for that. And you will definitely be hearing me talk about sugar sweetened beverages. Okay, so let's talk about body weight. Okay, so body weight is a bit of a hot topic, controversial topic in medicine, and especially in our community. Over 80% of Black women in the US are overweight or obese, and 71% of Black men are overweight or obese. When we just look at obesity, more than half of Black women have obesity, and a little over 40% of Black men have obesity. Now, interestingly, among Black women, obesity prevalence does not differ by socioeconomic status, and perceptions of overweight and obese status tend to be lower amongst Black women, and we're going to talk about more of that in a second. So Life's Essential 8 really models body weight over BMI, assessing whether or not you're overweight or obese based on the BMI cut points, which currently, if you are in the normal weight range with a BMI of less than 25, you have 100 points. If you're between 25 and 29.9, you are at a BMI of 80, and so forth. Now, here is the normal range. Here's overweight, obese category 1, obese category 2, and there's another obese category. Underweight is having a BMI of less than 18.5. Now, in some studies, we find that perceptions for norms of what's considered overweight or obesity differ in Black Americans, and this is both amongst adults and children. We tend to perceive larger body types as ideal. And so something we have to think about is how might this affect clinical care? If our perception of what's overweight what's normal weight is actually truly overweight, but let's say our physician hasn't told us that we are overweight or have, or that a conversation has not been perceived well because of how it was delivered by the physician, then we may not be likely to maybe take the steps needed to take off the excess fat. And when we think about body weight, I think we maybe need to change our thinking about being just overall heavier, but more so just having too much fat. We need fat, but we don't need too much fat, right? So it's about the total fat and the fat distribution, and I'll talk more about that in a minute. Now, one of the reasons why BMI gets so much criticism is because it was developed by primarily white cohort studies by these two scientists here, and they were also well-off white participants and white males at that. BMI also doesn't account for muscle mass or bone mass, and so Blacks, we tend to have higher BMI, but we have lower body fat. So obviously, that body weight isn't just reflective of having too much excess fat, right? It could be also bone density or higher muscle mass. Recently, the American Medical Association has noted the use of BMI as problematic and is now recognizing that we need to use more variety of assessments from looking at how much extra body fat we have and what we can do to reduce that. So things like looking at visceral fat and waist circumference. So even though BMI is not an optimal metric, it is still associated very much so with diabetes. You can see here, those with obesity have, those with diabetes, most of them are obesity, followed by overweight, and then here are normal weight individuals. Really quickly, I mentioned waist circumference, which can be used as a surrogate for visceral fat. We talk about visceral fat and subcutaneous fat as being the different storage depots for fat. We talked a little bit about this in the first webinar. Basically, visceral fat is the bad fat you do not want. It's associated with higher inflammation, greater insulin resistance, and this is the fat that's stored around your organs. So you can imagine that impairs the function of those organs. Some individuals are more prone to storing fat in the visceral depots and are also more sensitive to fat accumulation. I'm not going to go into these details about hypertrophic and hyperplastic in respect of time, because I do want to get to our panelists. But these is all about how well our fat functions to store that extra fat. So Life's Essential 8 is really structured around now these social determinants of health and understanding that there's different things in our environment and our psychosocial health that really impact how well we can meet these Life's Essential 8 goals. I'm going to skip through a couple of slides here, but I'll jump to this just saying that there's critical times where improving cardiovascular health is really important. This starts from preconception, even in the utero and in adolescence. These are important times to really make those life changes for better health. But really, it's a lifelong journey, right? We can make improvements for our cardiovascular health at any age. But when I talked before about the fat cells and how those fat cells function, some of that actually is determined a lot of it is determined early on, both in utero during pregnancy and in early childhood. So almost half of Black Americans have 2 or more of these risk factors that I just talked about. And so the question that I have for you today is, what risk factors do you have? I want you all to go home. Well, maybe you are home. After today's webinar is over, I want you to take the Life Essential 8 assessment. And remember, it is based off this scoring system. Just to give you an example, here's one I took a while back. I got a 91.9% score out of 100. I recently had a child, so I know I am not at that optimal rate just yet anymore. So I'm sure I have some work to do as well. Your empowerment actions today, take the Life Essential 8 assessment. Schedule a preventative care appointment with your physician. If you don't like your physician because you don't think they communicate well with you, there's some bias there, maybe you've experienced some racist issues, then maybe ask friends for referrals of other physicians that are more maybe racially or culturally congruent. Based on your Life Essential 8 score, I want you to create a list of 2 to 3 lifestyle change goals that you can achieve over the next 30 days, starting today. And then lastly, I want you to find a support system so that you can stay motivated. Here are some resources for you. Life Essential 8, you can read more about that here. You can calculate your BMI using this BMI calculator. And then if you need some motivation to get out and start walking, women, there is an online community of Black women who motivate each other to get out and walk. And for men, there is an online community for men to get out and run. So now I'd like for our panelists to address any questions that you might have. And if there's anything you want me to elaborate on that we didn't get to talk about fully today, then please do feel free to ask.
For anyone who may have joined us late, I just wanted to reintroduce our panelists. Thank you both for being here. We have Dr. Michael Shadia. He is a physician at the LA County Harbor UCLA Medical Center, where he spent 3 years practicing internal medicine and running his own diabetes clinic, as well as Janae Anderson, MPH and registered dietitian and nurse. She is a clinical dietitian at the San Gabriel Valley Medical Center, where she provides medical nutrition therapy and education to patients in an acute care setting. Thank you again.
Amber, do we have any questions yet for our panelists?
We do actually. We have 2 that have come through in the Q&A. The first one, can you explain the difference between non-HDL and LDL?
Her panelists want to take that, or I can take it?
You did a great job at it. Go ahead.
So basically, LDL is low density lipoprotein, and it's essentially traveling around. Imagine it's picking up, it's carrying around some cholesterol, and it's dropping that off in your arteries if you have too much of it, right? But HDL comes along and think of it as like a cleanup. You know how you have the trucks coming in and sweeping off the streets, cleaning up, getting all the debris out the way? That's essentially what HDL is doing. And it's taking that to the liver and clearing it out of the bloodstream. So the HDL is helping our blood to stay clear of that cholesterol, whereas LDL, when we have too much of the LDL, it's increasing the amount of cholesterol that we have in our blood. And so this is a risk because when you have a lot of LDL, that can lead to a buildup of cholesterol plaques, and this is what causes a a narrowing and a hardening of those arteries that can lead to elevated blood pressure, as well as strokes and whatnot.
Sorry, Dr. Shidia, were you going to weigh in something else?
No, I mean, she did a fantastic job about it. Just everything that she said. I mean, I can just how the LDL is the bad cholesterol, like she said, and that's the really one that we care about. We see a lot of patients with high HDL. This depends on usually Caucasians. Some people tend to have a higher one, but African Americans also do. We do definitely do have higher HDL. But in terms of most of the things that helps improve HDL in our body is exercise. In some cases in the past, people that drink moderate alcohol, even just maybe a glass of wine a day, tends to have a higher HDL than people that don't drink alcohol at all. But we don't tell people to drink most of the time because that leads to another problem down the road.
Yeah, so just to reiterate what Dr. Shadia was saying is, we do have now, not to negate what I said before, that, dyslipidemia tends to be lower in our community, but we still do see elevated levels of LDL, right? And so things that he mentioned, like getting exercise, is important. But also there are some dietary components that can lower cholesterol levels, like LDL or total cholesterol. The DASH diet is a really important one. He mentioned wine, which there's now a bit of a debate about that, actually. So I guess I won't co-sign, but I do think it's beneficial personally, but we still need more research to really understand if that belief is maybe not as accurate as we once thought. And then nuts. So, part of the DASH diet is really about the Mediterranean diet, which is consuming a lot of moderate amounts of healthy fats. And these are things that are found in, salmon, for example, or nuts. And, you might hear of like fish oil sometimes being prescribed, which that's a little bit of a debate on whether or not that actually impacts anything. But certainly diet and exercise are great. And if you have elevated LDL, certainly consult with your physician and figuring out if you really should be on a statin or not.
Fantastic.
Sorry.
Please feel free.
I was going to chime in. I think the question is also kind of specifying the term non-HDL versus LDL. So if it's LDL.
Oh, I'm sorry. Was that?
Yeah.
Thank you, Janae. Go ahead.
Of course. So that doesn't necessarily mean that if it's not an HDL, it's going to be an LDL. So a good way to think about it is think about all of the cholesterol or fat and then subtract what is an HDL, and then that will be considered the non-HDLs. And that can include LDLs, triglycerides. There are different types of lipoproteins as well too. So that doesn't necessarily mean if it says non-HDL that it's going to be LDL.
Great, thank you.
Thank you. There are two questions related to HDL, which I think you kind of touched on, but just to make sure that our participants feel good about that. Oh, I see a thank you already that answered it for you. So I won't go ahead and read that one that's in the chat. But another one that you did kind of speak to, Dr. Price, is which foods produce a higher HDL?
Oh, that's a good question. So which foods produce a higher HDL? I don't actually know if there's any foods that will increase HDL per se, like HDL specifically, but more so the foods that I mentioned a minute ago are foods that will improve your dyslipidemia. So remember I mentioned the dyslipidemia is about the balance of good cholesterol, HDL, and other cholesterol, LDL, total cholesterol, there's intermediate cholesterol, et cetera. And so it's more about changing the balance and helping clear out the cholesterol from your blood. So those foods can maybe help improve your lipid profile, and that might then look like you're improving your HDL, but it also would maybe improve your, lower your LDL levels, or maybe your HDL doesn't change, but your LDL levels are changing. So I don't know if there's anything that's specific to increasing HDL per se, but more so thinking about it as your overall lipid profile and balance. Janae, I don't know if you have anything to add to that.
I would agree with that statement. And also a good way to kind of help with lowering your cholesterol is increasing your fiber in your diet. So that includes things such as, whole foods, grains, broccoli, different vegetables that can help with fiber, essentially lowering your cholesterol that way. And I agree with the nuts, salmon, healthy fats like avocados to kind of help with the lipid profile overall, but there's not going to be a specific food this is going to increase your HDL. So.
Fantastic. And Dr. Shadia, I saw that you unmuted. Were you going to also chime in?
No, not about that question, something else. One of the other questions that they have there, but we'll go down the list.
Okay. While we're talking about diet, there is a question in the Q&A box wondering, should African Americans follow a Mediterranean diet?
Oh,
Yes.
100%. Janae, I'll let you, this is your wheelhouse. I'll let you take that one.
So yeah, I think it's a good idea because it does follow closely to the DASH diet that we were discussing earlier with the healthier fats, such as avocados, olive oils with those vegetable oils. And it has lower sodium, which also helps with cardiovascular disease as well. So it's such a great kind of overall diet that is good that African Americans as well as non-African Americans should follow. It's a good idea. You don't necessarily have to follow it, but it's a great diet if it's something that will keep you on track. That is a good idea to follow.
Thank you. Moving us along, another participant is wondering, can we differentiate overweight versus obesity?
I was just typing that answer in the chat. Dr. Shadia, did you want to answer that?
I mean, so obesity starts with a BMI greater than 30. So if you are between 25 to 29 or 26 to 29, that's when we say that's when we say overweight. But anything above 30 is obesity. Then there's morbid obesity, there's obesity, and morbid obesity, you're looking at 35, BMI of 35 to 40. So it's just a different ways to class things. Because, sometimes for morbid obesity patients with a BMI greater than 35, sometimes our approach is to refer you for surgery because your complication, it depends on all the comorbidities that you have too. Then for patients between 30 to 35, if they have 3 or more comorbidities, sometimes then we refer them to surgery. It's just a way to differentiate things and to know how to manage them. That's why we go by all this: overweight, morbid obesity, and normal obesity.
And when Dr. Shadia mentioned comorbidities, that means that you have more than one chronic condition.
Yes, I'll try to use regular
No,
language.
it's okay. I just want to make sure the audience understands. I hope that answered the question. And you can refer to that BMI calculator. That'll be sent out along with the survey, and you can calculate your BMI.
Fantastic, thank you. Another question that we have is, what is the best way to reduce or eliminate body inflammation?
Well, it depends on what's causing the inflammation. Inflammation is different things around the body. It could be because you have a specific disease that's causing inflammation. It could be because of malignancy. So you have to figure out what's causing the inflammation. If you bump your knee on something, it's going to be inflamed for a while. So then there's a different way you treat that. So there's no general term about, this is how you reduce inflammation, because if you have a specific infection that's causing inflammation, the treatment is to give you antibiotics to treat the inflammation. If you have an inflammation because you have a viral disease, the whole thing is for you to let the body take over. It's going to take about 7 days for that to resolve. If you have an inflammation because you bump your knee on something, then it's going to be anti-inflammatory medications like ibuprofen, ice, some gel, Voltaren gel over the counter that you apply there. If it's malignancy that's causing inflammation, by malignancy, I mean it's cancer. Your treatment is to treat the cancer. So inflammation is, I know they use that loosely, it means different things. It's like a whole spectrum. So we have to know exactly what's causing what.
Yeah, so when we're talking about inflammation in this context, if you're, looking, there's one, your physician is probably not going to necessarily, they might look at CRP, which is C-reactive protein, which is a common marker of inflammation, but it is, like Dr. Shadia said, it is a marker of inflammation for many different things. So it really does depend on what is going on that's causing the inflammation. But let's just say you don't have any injuries or any other issues, and maybe your inflammation is due to being overweight, which is a very common cause of sort of general inflammation, I'll say. So reducing body fat can help to reduce inflammation.
Thank you. This is great. I know that we've got about 3 more minutes and we have a few more questions. So I'm going to try and get us through these quickly. Are the A1C levels the same for seniors and non-seniors?
The simple answer to that question is yes, it's the same. A1C doesn't change. And the only time you see a difference between A1C is for patients that have red blood cell disease, sickle cell, thalassemia. So their A1C at that time does not correspond to what it actually is. Some cases, because they have a red blood cell disease, it can be low. In some cases, it can be higher, but we have other tests that we do if that's the situation. Your physician is going to know what your background is, and they know what kind of test that they do in that situation to get it. That's a test called fructosamide that we use, but I'm not going to bore you with that details. But simple answer, if there is no red blood cell disease, A1C is the same for everybody.
Thank you. Another question we have, does genetics play a role in developing cardiovascular disease?
Yes. Genetics play a key role in developing cardiovascular disease in all aspects of it. So high cholesterol causes cardiovascular disease. Some patients are born with their body just produce high cholesterol because they have the gene. There's a particular disease they call FH, familial hypercholesterolemia. You are born with this gene that your body just go crazy and synthesize high cholesterol. For those patients, they have a heart attack in their 40s very early. So if they starting very early, they have a lifestyle modification. We have this particular diet, the Mediterranean diet we're talking about, that they go on. So that happened. And you see, there's a lot of people that they don't have that particular disease. It's just in the middle. They have high cholesterol. They're like, well, I'm not eating burger all the time, but I'm having high cholesterol because the gene aspect, their body is producing high cholesterol. That's why they give it a statin medication to limit the amount of cholesterol that the body produces. Diabetes, contrary to what people think, is what they call type 1 diabetes. It's genetics. Type 2 diabetes, that's also happened due to environment, lifestyle, and what we do to ourselves. It's also genetics. Studies have shown that if your parents have type 2 diabetes, you have a 30% chance of having type 2 diabetes, which can then lead to cardiovascular disease. People that have diabetes die of heart disease, heart problem. If both your parents have type 2 diabetes, you have a 66% chance of having type 2 diabetes. So there's a genetic component of it that happens. So all this leads to problem with the cardiovascular system.
And there's also something called lipoprotein little a, which seems to be elevated levels of that seem to be higher in African Americans as well. And that's associated with, dyslipidemia, which of course increases your risk for disease. With all this said, that does not mean that you are doomed to have poor cardiovascular health your whole life. So there are, take the steps for improving your cardiovascular health, because at the very least, sometimes it's also about delaying the event, right? There is one thing to have a heart attack at 50 versus a heart attack when you're 102 years old, right? So this is really all about prevention. Right.
Which is what this class is all about.
Exactly. But it's what Dr. Shadia was saying in terms of family risk. This is why it's so important to know your family history, and that's why the physician asks for your family history, because these are important things that do play a role in, when you might get screened for something, or you know, maybe how regularly you need to visit your doctor if you do have one of these predispositions to a disease.
Yes. Just perfectly said. Just, you know, having a predisposition to a disease means you have to see your clinicians, you have to take your medication as prescribed. Unlike somebody that has no problem, then after the age of 50, they start going to the doctor and they start taking the medication. It's different because if you start taking things like, oh, somebody, example, my parents, when I was in medical school, my dad has one of those genetics component of it, maybe not severe, had high cholesterol. They gave him statin medication in his 50s and he left it on his table saying the doctor is trying to kill him. Then I came home from school one day, just came home to see my parents, and he has all this statin medication, about 10 bottles. He decided not to take any of it. They said, because I don't eat burger, so my cholesterol should be down. My doctor is just trying to kill me. I had to explain to him that what statin medication is doing, it doesn't have anything to do with your burger or no burger, because you are predisposed to this. You have to take the statin medication to limit your cholesterol in your body, to prevent you from having a heart attack very early. So, you know, knowing all this, you can intervene early. Then you can limit the risk factor, and that you can prevent yourself from having a heart attack down the road. That's just what all this means.
Great. This is such a great conversation. In the interest of time, I'm going to read out 2 more questions that we have here. And I know that Ambria is dropping our post-event survey in the chat for you all. That is another opportunity to ask any questions. And I monitor that and can get back to you with answers if anybody didn't get their question answered here tonight. Around cardiovascular health as well, I see, Candice, it looks like you're typing an answer to that. But the question is, how does coffee affect cardiovascular health?
And maybe I should let Janae take a stab at this if she has anything to say first before I chime in.
I would say mainly the caffeine and the coffee kind of, you know, elevating and the blood pressure, so increasing blood pressure, which can essentially lead to, you know, altered cardiovascular health, which is a main thing I think the caffeine in coffee is to do. So I don't know if you have anything to add with that
Yeah,
one.
so no, I would agree with that. And also, interestingly, I think the caffeine consumption is a little a bit of a debate, but the research has shown that caffeine can be helpful for maintaining insulin sensitivity. However, the caveat to that is too much caffeine consumption, like Janae said, can, you know, interfere with blood pressure control. And so you have to find a balance. I think it's important to see understand where your metabolic profile is, because some people are more at risk for consuming caffeine than others. And this is especially important if you do have type 2 diabetes and you're on specific medications that can actually caffeine can affect that.
Some people are more sensitive to caffeine than others. So unfortunately with diet, a lot of the times it's very individualized. Some people can drink, you know, 3 cups of coffee. I wouldn't recommend it. But a cup of coffee a day shouldn't be too detrimental to cardiovascular health in general. But yes, I would check with your physician just to get kind of what your base level of cardiovascular health is at from the beginning.
And if you're drinking caffeine regularly because you're not getting enough sleep, let's see how we can get more sleep.
Great. And one last question. Thank you to our panelists as well for helping me out with answering some of those questions directly in the Q&A box. Is it true that metabolic syndromes such as having CVD, the A1C would be increased?
CBD?
I think they mean cardiovascular disease.
Oh. Can you repeat the question?
Yeah, I think it is cardiovascular disease as well. Is it true that metabolic syndromes such as having cardiovascular disease, the A1C would be increased?
Yes, your metabolic syndrome increases your risk for cardiovascular disease. Metabolic syndrome means you have high cholesterol, high glucose, which you can see with, or diabetes, which you can see with a A1C greater than 6.5. All this, they lead to cardiovascular disease. So when you tackle what causes the metabolic syndrome, or you try to limit or control the metabolic syndrome, and you can then reduce the risk for cardiovascular disease. And part of the metabolic syndrome is also obesity, excess weight, losing weight, exercising, taking your medication. Yes, with circumference, these days we use simple term belly fat, that you take into consideration. There's a particular weight the weight circumference that is required for men and that you want for women. Then you also factor what their lipid level is, what their hemoglobin A1C is, what's your diet like, how many physical activity do you do a day. So when you try to attack all essential aids, all aspects of it, which also are all part of the metabolic syndrome, and then you can then reduce the risk for future cardiovascular events.
Great. Thank you so much. This was a great conversation. Ambria, can you take us to our upcoming events slides?
Yep, give me just a moment.
As Ambria is doing that, I want to thank you all again for being here with us today. I am very excited about this conversation and the series that you are leading, Candice. Thank you again so much for everything. I want to make sure to share the dates of our upcoming sessions. We will be having session 3 of our series, Control the Controllable. We'll focus on breaking barriers to healthy eating. On Thursday, August 10th, session 4 will cover exercise and diabetes prevention on Thursday, August 24th. Also happening on Thursday, August 24th, we will have a different series under our Health for Life initiative, which will be managing caregiving for loved ones. It's all about caregiving in the Black community. Session 5 of this same series, Control the Controllable, will focus on sleep, your body, and diabetes risk. That will be coming up Thursday, September 7th. Also on September 7th, we will have our Caring for the Caregiver session, under the Caregiving for the Black community as well. And then session 6 will be Managing Stress and Balancing Diabetes Prevention, happening on Thursday, September 21st. The remaining sessions of this series will be at 5:00 p.m. on those dates. And so we hope that you all can join us. Again, if you had any questions that you did not get answered today, please do feel free to utilize that SurveyMonkey link. You can ask your questions directly into the survey, and I will be sure to get back with you with those answers. So with that, thank you again so much for being here with us tonight and for hanging on to the very end. I hope you found value in this, and we look forward to seeing you again in 2 weeks. Have a great night, everyone.